DJ LeRoy.
NightWatchman. How you doing, buddy?
I'm well.
Good, good. You know that the what was it? I believe it's the Frederick Douglass Boulevard Alliance. They had a nice little ceremony last week, man.
I heard about it. As a matter of fact, I believe you were one of the honorees. Congratulations.
Me?
Yes.
Well, man, I know. I want to thank you and Marie for coming through, man. That was beautiful. I mean, and Karen and Marie, they just had this connection. So I've been told, I've been put on notice that, oh my God, you guys were going to be invited to come to dinner.
Oh wow, that sounds great to me.
All right, there you go.
So let's get to the order of the day.
Okay.
We're talking about health today, correct?
Yes, we are. Yes, we are. As a matter of fact, we have one of our returning guests, and that could only be Dr. Danielle Greene, or as I say, Dr. D.
Welcome back, Dr. Danielle.
Hello. Good to see you again, Night Watchman, DJ LeRoy. How are you?
Good, good. See, and I love her because she pronounces it correctly. It's not Leroy, it's LeRoy. Remember, it's French. Remember that. Okay?
All right. Beware of people declaring themselves the king.
Wow.
I'm a legendary of kings these days.
Yes. Night Watchman, I can't believe you're bringing heat already. This is quite nice. I like this. Okay. Well, you know
that
what?
wasn't meant at you. That was you know. If you know, you know.
If you know, you know. Exactly.
Yeah. Well, I definitely have to, of course, bring out the founder, man, of course, Medpod, which we're going to be talking about, Jack Tawil. Yes.
There we go.
Welcome, Jack.
Thank you. How's it going?
Beautiful.
I'm not going to even try and pronounce your name. No. LeRoy. DJ LeRoy.
Correct. You got it. There you go.
Doctor D.
Jack.
Man, oh man. So all the way, with the partners there at Medpod, all the way from where? Can I say South Carolina, South Shakalaka? Ed Miller, bring him up.
All right.
There we go. We got. See, at Night Watchman, what's going on here? There's our technical stuff.
There he is.
Ed, what's up, buddy?
How are you?
Good, man.
South Carolina is in the house. Amazing.
South
Carolina.
All right.
Okay. Well, you know what? I have to answer because remember, I'm here in the Big Apple, or what I should say, the frozen apple. So, what's the temperature like there?
It's in the 40s. It's a little on the. No, I'm wrong. It's 30 degrees.
Ooh,
okay. So
wow.
Not much better than here.
Well, you know what? Let's get this popping here, Night Watchman. So, Jack, do tell us Medpod. Give me an overview, description of Medpod, and why it is revolutionary for the average citizen.
Right. So Medpod is actually a diagnostic telemedicine platform. It actually allows for full diagnostic to happen using the digital platform, using telemedicine. So the provider could be anywhere, the patient could be anywhere, and you could actually provide care as if they were physically in the same room together. And that really changes the way that you could actually deliver healthcare, where you could have literally some of the best doctors from anywhere. Of course, licensed in the state that they're operating in, but they could literally be anywhere and providing care in that other location with wherever the patient is, and that's exactly what we're doing in the MediLink WellCheck Harlem clinic on 145th Street and Malcolm X Boulevard.
Beautiful. And you know what? One of the things, looking at your background, Ed, you're coming from the military background, so do tell me what has attracted you to Medpod, please.
Well, I was Governor Henry McMaster had called me probably going on 3-4 years ago, and said that he wanted me to go over to South Carolina Department of Disabilities and Special Needs for the state of South Carolina, and help shape it up. So I was appointed as a commissioner. And currently, I'm the chairman of South Carolina Department of Disabilities for the state of South Carolina. I met Jack some 7 years ago, and he was talking about community health care. And, you know, I'm no stranger to Harlem. So he came down to South Carolina and did a study in Summerville, South Carolina, with the IDD population. And I said, and I noticed that he was doing something called baselining. And I said, Jack, that's new. Tell me about that. And he said, well, baselining is basically, I'm going to thoroughly check you out and tell you where you are currently health-wise today. And then from that, wherever you go from that point, we'll have it in a database system where whenever you go to the doctor will be able to see your current condition versus where you were before and say, well, Ed, you need to kind of look at your diabetes level because we see something that could possibly change. So I got involved, and here I am back in Harlem.
Welcome back, man. Welcome back. So, Dr. Danielle Greene, please, I want you to tell me about you, the CUNY School of Public Health, and of course the Harlem Health Initiative, and why that is so important in terms of looking at the core morbidities of a community like Harlem and Northern Manhattan.
That's all. So hi, I'm Danielle Greene. It's great to be back here. I'm the Executive Director of State and Local Public Health Initiatives for the CUNY Graduate School of Public Health and Health Policy. And I work very closely with the Harlem Health Initiative, which is part of our community-focused work and has actually spread well beyond Harlem. But the idea is, as a school, our mission is to improve community health in partnership with the community, as well as teaching the next generation of public health leaders and conducting research that will do good for everyone and that the community can participate in. So through the projects of the Harlem Health Initiative, which ranges from vaccine education to community surveys on things like cannabis attitudes and beliefs, to other educational seminars, to blood drives, to collaborations with the community in the Harlem Strong program, which is about bringing mental health services at the community level. We're interacting with the community every day to figure out how to improve the services, the infrastructure, the life in the community, which will enhance health.
Excellent. Yes, you covered it. Beautiful, beautiful. I then also have to ask this. Okay, so Jack, certainly Bob and I grew up, of course, at a time on television where we had Marcus Welby, MD, we had Dr. Kildare, you know. So I remember the doctors with, of course, the black bag doing house calls. Tell us, does Medpod encapsulate that?
It does. I mean, so it's the next generation of that, of the house call. One of the Medpod units is actually called the mobile dock. It actually shrunk down the equivalent of a hospital cart into a travel size carry-on bag. And in that bag, it would wheel into the patient's home or any environment. And it would stand up tall like a hospital cart in about 30 seconds, have the doctor come up on the remote side, and then have all of the diagnostic equipment physically there. And very easy to work with. And so your full vitals and your full scoping capability and EKG and spirometry. And then there's additional add-ons that we would bring alongside it if necessary, X-ray and ultrasound and so on. So very, very comprehensive, much more comprehensive than that little black bag. And it's really, it's real healthcare in any environment. Of course, in our clinic as well, but even in other environments.
You know what? It's so funny. So when you were doing the demonstration in the office, Jack, I remember this classic scene from Pulp Fiction when they came across the suitcase and then they slowly but surely opened it up and then voila. I mean, do tell. I mean, that must be a pretty penny.
It's not inexpensive. So again, Medpod is the actual developer of the technology. In the clinic under the brand MediLink and with the well-checked doctors, we're using Medpod technology, but and we're also launching some of the newest Medpod technology in that clinic itself. So they'll be some of the first to get it in the world. Medpod technology is out at about 500 locations at this point. So this is not something that's new when we're testing. It's actually in use, all over the world in some of the most remote locations. and even on some very famous people's yachts.
Wow, wow. You know what? I kind of think, and a night watchman help me here, because I'm thinking about when we talk about rural locations. Of course, Ed, I'm thinking about you. I'm thinking about South Carolina, man. So do tell me, do we have any locations of MedPod there yet, or is that to come?
No, we have a location in Maysville, South Carolina, where MedPod is currently located, along with Deloitte, and Jack can tell you more about that. Absolutely. Home of Dr. Mary McLeod Bethune.
Absolutely.
You know, I have to plug this in. My wife is the grandniece of Dr. Mary McLeod Bethune, and she served as mayor for 12 years. So she says, bring me some health care to Maysville. So here we are.
Oh, beautiful, beautiful. And you, go ahead.
I'll just add, and in South Carolina, we're actually working on an entire state-based program, but there's a program together with Deloitte and SC Bio, which is the bio agency of South Carolina. We're actually baselining a bunch of patients. I can't say which companies, but there's some major companies involved, and that will get launched in the next couple of months. We're also in the Charles Lee Center, which is considered the center of excellence for the IDD population, the intellectually developmentally disabled population in South Carolina, and from there branching out. So we have pretty good coverage in South Carolina, but we do the same around the country.
Beautiful, beautiful.
And thank you for spelling out IDD, because I didn't know those initials.
Well, hold on, Night Watchman, you know everything.
Yeah, I should add that IDD, the program started in New York, so it didn't start in South Carolina. It was actually the New York State BIP Innovation Funds that actually put the dollars forward. If you remember Steve Simbowitz, I was actually with him earlier this week. He was the one who actually brought it in to New York. Actually, ultimately, our case studies proved that we actually reduced hospitalizations by 86% for that population, the IDD population. We would push into their homes, their group homes, and disrupt the normal care pathway, which was going to the hospital on nights and weekends. Major bills to the state of New York. And so when you have an 86% reduction in hospitalization, in 6.5 months, the state saved $2.4 million on a $250,000 investment. So major return on investment that became law in New York State. And essentially we started to move from there. So it really all started in New York.
Wow, wow. And Dr. D, you know, I'm falling back and going to defer to the experts. So Dr. D, what do you got for us? Do tell.
Thank you. So I'm listening, and it's great. I hear the business case for it and the return on investment. And I know, Curtis, you mentioned how you liked all the shiny brightness of it and all the buttons.
Yes, I did. I like buttons and knobs. Yes, I do.
Yes.
Okay.
I'm looking at it from the community and the patient point of view. And I have some questions about, who is it? So it seems like there's two models. You can bring this to someone's home, or it sounds like Jack has set up a clinic in Harlem where he's using the machines in a set location that people will come to. And then doctors are telehealthing in through the video portion of it. So can you talk a little bit about what kind of professionals are running these machines? Who's working in your clinic? Who's bringing it to someone's home? What kind of level of training do you need to be the person with the patient and the machine?
Sure. So we call them care facilitators, the person that's physically with the machine. And they generally are licensed, right? So usually it's an RN, it's an LPN, it could go down to the level of MA phlebotomist, right? Into that, or even an EMT, a paramedic. Generally, that's the population of worker that's working with the patient. On the remote side, it's the doctors. On occasion, it's nurse practitioners, PAs as well. And it's really, it starts with primary care, but it's also specialty care. And that's one of the beauties of Medpod, is that we could really bring on the spot specialty care. So if your primary care says, I really want you to do an EKG and I'm concerned about your heart, we could bring the cardiologist right in. You don't have to come back. And we could do the same thing for the pulmonologist and so on and so forth. So that's one of the advances of Medpod. But even more important, it's the way that we capture the data. We call it high fidelity data, and that of clinical data. And that data really becomes very important. One, it's important for the future, right? From the standpoint of everyone talks about AI, right? AI in healthcare. And you need high fidelity data to be able to actually have useful AI in healthcare. Otherwise, you actually have what they call hallucinations, right? The data is wrong. And everyone asks me, well, we have EHRs. Why can't we have from the electronic health record? My doctor's been taking my record for the last 10 years, 15 years in certain cases. And why can't we use that data as the baseline? Reality is it's actually not good data. It's actually corrupted data. Very, very, very often, one, they didn't capture the type of data we're capturing, which again is high fidelity. So if I'm listening or the doctor's listening to your heart, I'm recording that heart sound. If I'm listening to your lungs, I'm recording that sound for future reference. I'm also, when I'm using scopes, I'm looking in your ear. You could see your ear up on the screen. I could see your ear. The doctor could see your ear. And so we could then record video or stills of that. And the same thing with dermatology, and the same thing with checking the back of your throat and things like that. So all of that data comes together to form the basis of that high fidelity clinical data, where you look for deviations from the norm, right? Hey, something's going wrong. What were you before? And then did you deviate? And one further aspect of Medpod is that every one of our units, even though there's over 500 out in the market, if you use our units, let's say in New York, or use them in California, or use them in Alaska, or wherever it may be, it's the same equipment, right? It's the same exact experience. And so that creates consistency in the collection of the data. And then if there's a problem, we know it's a deviation from your norm, not the machine that you were tested on. That becomes very important. So overall, Medpod is one, solving healthcare access issues, but we're also dealing significantly with the disparity.
Gotcha.
Right, but then that data is then uploaded into someone's primary care chart with the primary care physician in the or nurse practitioner in their electronic health record. In New York, we try to have all those health records shared through the Shiny so that they are available to you wherever you go for care. So then are those systems actually prepared to receive all those digital files and videos so that it is available when you get your next specialist who maybe isn't connected to your system?
Yes. I mean, so you asked a very good question in that I don't think part of my background, but part of my background is I created the Walmart medical centers originally, which were those convenient care clinics. I actually was the one who named them convenient care as well. But one of my speeches in 2006 at Walmart became the basis for DASIA. DASIA is the not-for-profit that ultimately they modeled the Health Information Exchange Act on. And so you just asked about Health Information Exchange. The Medpod essentially works with over 100 electronic health record systems. And if you think about FHIR protocols, which is really the current HL7 protocol, that's a grandchild, so to speak, of what I proposed originally in 2006. And so we're very big on sharing of data and presenting that data. Now, not every electronic health record could actually take in the type of data that we create. So we send the data that they can actually handle. If they can't handle it, we'll send them a link back to our systems so they could actually, let's say, render the video that they couldn't support.
Gotcha.
How is the data protected? What are the privacy?
So it's a pretty robust data structure. So, of course, it's HIPAA compliant, but it's also GDPR compliant, which is the European standard, which is higher than the U.S. It would be most similar to the California standard. So it's protected. It's actually bifurcated. The patient's data is separate from the clinical data. It only comes together and renders on the fly. It's exceptionally protected. Of course, encrypted as well.
Gotcha. One of the things I want to ask, so NightWatchman, if you give a quick little overview of the Harlem Emergency Network, and wondering if, let's say, having access to, let's say, the tools of Medpod, would that be something beneficial, especially after there is a health or what's the environmental catastrophe in the community? Tell me.
I would say that we're not equipped to handle this. Medicine is a whole nother realm outside. We do support disasters and we do interact with Department of Health and things, but we leave the professional work to the professionals, and and that's where it should stay.
But I do think you're onto something, and NightWatchman, tell me if I'm wrong, but I could picture, wearing my emergency hat, a situation where if you were having to, say, like a Hurricane Sandy type emergency, where you were gathering people safely in a large place to shelter or for resources, and people were disconnected from their medical care, I could see machinery like this with care facilitators being efficient for triaging, is someone having a heart attack, or are they just feeling anxious after everything? They got separated from their medications and you quickly need to find a way to re-prescribe things, and checking on that. Like, I could see it being very useful in situations like that.
Yeah.
Oh, yeah. So what I would ask Jack about is what are the I guess the protections for emergencies where, first of all, how do you transmit the data? Are you doing it through cell, 5G cell, or or is it satellite? And what happens in situations where power goes down? Are your Medpod still operational, or do you have some sort of backup protocols?
Absolutely. I mean, so first off, from a disaster recovery standpoint, there's a major opportunity to change disaster recovery around healthcare. One of the proposals that we actually have, we're speaking to some of the people within New York State, is actually having a pool of Medpod mobile dock and MedPack. It's a backpack version of the mobile dock that are available, that they would actually have for the disaster recovery situation, and then loan those out to the community, right? So that the community would be able to utilize them. We would train care facilitators in the community, and when there's a disaster, it would actually go towards that disaster zone, right, wherever that may be. So one, physically, you would actually have the infrastructure to deal with the disaster. And then the second part would be the doctors, the providers, nurse practitioners, PAs that would be on the other side. And in the disaster, that's one of the biggest issues, is that very often you have people coming right away in the first days or first couple of days, and then they go back to their life, right? And the follow-up care becomes a bigger disaster, frankly. And so the ability to actually utilize Medpod, where those providers could go back to wherever they are, and actually then do follow up, right, with the patients that they may have treated live during that initial touch. We could solve that problem, but we could also create more capacity, right, in that disaster. There's a real example as far as the infrastructure and the network, where we just finished a pilot program in Malaysia, and it was actually sponsored by Intel and a company called Amdocs. Amdocs is a big infrastructure player. They actually build cell towers. They're one of the biggest cell tower builders and infrastructure builders for Verizon, AT&T, T-Mobile, and a whole bunch of others. And in that scenario, of course, we use, and we're on the back of 5G or 4G. But in that scenario, they actually went into rural villages that didn't have any infrastructure at all. They didn't have power. They still don't have power. They don't have cell. And what they did was they brought Medpod in. Our mobile dock, they actually brought in a mobile cell tower. It actually looks similar to a Medpod mobile dock unit. And so they wheeled these two units in. They actually used a generator in that scenario, because there was no electric there as well. And they were able to power it up, stand up a cell tower, and actually transmit Medpod over that. They used the Starlink satellite network as a backhaul network, right, to deal with the backhaul flow of traffic. So we work on all infrastructure. We work in scenarios where there is no infrastructure, and again, in the disaster recovery, we could actually propose an entire program between Medpod, Intel, and Amdocs, just with those partners alone, to be able to deliver care in any situation.
Beautiful. And Dr. D, one of the things, certainly we do know in a city like New York, and especially when we saw this, it seemed like rash of violence. We were talking about mental health stuff, really. That was the serious, say, determinant of a lot of stuff that was happening there. Now, mental health, especially in Black and Brown communities, they don't, let's say, talk about it as much as it needs to be addressed. Can you see something like this, like telehealth, telemedicine, being a benefit to those type of situations?
I think telehealth is a huge benefit to those type of situations. As you know, CUNY's School of Public Health is doing a lot of work about trying to increase the ability of community health workers to address stress, anxiety, and depression among the community. I think telehealth is a great way to increase access to mental health care. I think you don't need an EKG, you don't need a stethoscope, you don't necessarily need, your temperature taken or any of these things for mental health. But if there was a question about what's the health issue versus a behavioral health issue, or if an assessment like this, you could then say, you know what, you're actually physically okay, but we're going to use the telehealth to connect you with somebody as a first assessment for mental health. Is it to get the person over the barrier? Because there's also a lot of stigma around admitting you have a mental health issue or even seeking care. So if it could break that barrier down, it could be a good thing.
Absolutely.
Yeah, I'm going to just add on that point because we work pretty closely with mental health, and Ed, we've met in South Carolina with the chairman of mental health as well. There's of course when you're having consultation, but you can just do it on video. But there's this other aspect, and New York faces this all the time, where the patients that are actually on medications around mental health or treatment actually need to see their doctor, need to get their vitals taken and other assessment. And this becomes very, very useful equipment in that scenario. So there's cases in New York State where some people upstate actually have to travel 5 or 6 hours to physically see a doctor so that they can continue that medication, and they're doing it every month.
Absolutely. NightWatchman, what you got for us, man?
I wanted to ask Jack a little bit, since you're operating both in South Carolina and in Harlem, what are the different challenges in working in an urban area versus a rural area?
I think it's very similar. I mean, from the standpoint of access to care, people think that because Harlem is 10 minutes away from, I would say, one of the centers of healthcare right in the country, that they have access, but they don't. And I think there's a good example in that the level of a provider that's available to the community is not necessarily always been the highest level. And I'm not disparaging any providers that are doing great work in the community, but the real example, every Thursday we have a doctor, his name is Dr. George Dempsey, who actually comes in on our equipment and is available to see patients in the Medilink Harlem Clinic. And he is out in the Hamptons. So from a physical location, he couldn't actually physically come in, once a week or whatever it may be. But he's also a doctor that's treating or has been treating some of the people in the White House, right, for years, for the prior administration. And so a doctor of that level, right, would not necessarily be able to come in to the Harlem Clinic, but he's available to the residents of Harlem because of the technology. And so that changes the way that healthcare is delivered. And it really doesn't matter if it's urban, suburban, rural. We're facing a shortage of providers in the country. And I make a controversial statement, but I think it's very true in that we actually don't have a physician shortage. We have a distribution problem. And we could use technology to solve that distribution problem.
Gotcha. You know what? And Ed, I have to say, what has the reception been in South Carolina in terms of a Medpod?
Excellent. Matter of fact, to my surprise, they did a chart, and Jack had mentioned that I wasn't aware of it. Charles Lee Center, which is one of the providers for DDSN, but they are independent. And Jack can talk a little bit about that because I saw the video where Fox, what was it, Jack? Fox News?
Fox News, South Carolina.
Mhm.
So Jack can kind of elaborate on that because I wasn't even aware that that was going on. But they use their own private monies to get Medpod in there and study that population, and they got very positive results. I think Jack sent it to you as well, Curtis.
Yeah.
Yeah,
So,
And also,
Uh-huh.
Jack, speak on that issue, but I also want you to talk about the sick and shut in that cannot get out of their bed, or they call for ambulatory services, and all of that costs time and money, and how we can help that population.
Yeah, in that population specifically, right? And the Charles Lee Center deals with the intellectually developmental disabled, so it's one of the most difficult populations to deal with. If you could treat them, right, in their example, treat them in their home, we picked up that the anxiety levels actually went down by 94% for those patients. And so everyone forgets about that part, right? But it's really dealing with a unique patient population. But very similar, the patients that are, frail elderly or sick and shut in, transportation related issues where we could actually come to them, provide care where it's most comfortable for them. It also deals with this other issue of white coat syndrome, right? Where sometimes they come to the doctor and they're not really they're not comfortable. So the readings are off. It looks like it's elevated pressures and things like that. And really it helps bring down that aspect of the examination as well.
So one of the things, Dr. D, that I heard from Jack, of course, was distribution. I think of course, of one of the big companies, of course, Amazon. What did they do? They solved distribution, getting your package, whatever, there. Is that a big thing in terms of healthcare, especially in a community like Harlem?
Distribution of providers?
Yes.
Yeah. So I do think we have a primary care provider shortage, but I also agree that you have overage of doctors in some places and a lack of doctors in others, particularly rural areas, even rural New York, even areas of the city, you'll have more doctors than others. So I don't know that Amazon can fix our distribution problem, but if they can just pick up the doctors with their drones and drop them in the right place.
I actually could say, I'm going to add something controversial. I actually think they can help fix our problem. We've been working with them for the last couple of years. With their global medical director actually is a very big supporter of baselining. And again, we've gone into depth as to how a company of that nature could help change and really change the landscape of how care is delivered and digested.
And Jack, before I jump in there, because I'm sometimes a novice, so do explain exactly what is baselining.
So baselining is doing a comprehensive examination of you at a given time, right? And so when I say comprehensive, it's very similar to like an annual wellness type of visit, but it goes further. It goes further in that instead of me describing what your heart sounds like or your lungs sound like and physically typing it in, we're capturing that actual data, right? The real objective data, and we're taking images as an example using our exam camera. And picking up on things that we may not know what we're looking at, right? So we take a picture of your face, and then the doctor draws a line across it, and they start to look at, is there any droopiness ultimately between one picture and the next, potentially indicating that there's something going on, right, from a stroke perspective. The same little image could also pick up on if you're having any type of issues with your back or your hips and alignment issues and so on. So there's a lot that's going on in the baseline. If we're doing the baseline in the home, there's even discussion of taking water samples. So actually start to bring in other social determinants of health into the baseline. So it becomes very comprehensive. That data is being organized by one of the biggest auditing firms in the world, Deloitte. and they have a major staff of doctors and medical practitioners on their staff itself. And so we're working with them to say what is important in this baseline. How do we actually categorize the data? How do we store the data properly and have it available, right, for the big bio agencies to deal with?
Gotcha. So Dr. T, one of the things I heard from Jack earlier was the whole notion of, let's say I'm an elderly person. I don't feel like going to the doctor, or there's a snowstorm out there in terms of being shut in. So do you actually hear that a lot from the Black and brown community that you serve, that they don't feel like traveling to their primary care doctor, or what? What are you hearing on the ground?
So I think that for people with any kind of disability, for older adults, for people in congregate care settings that have limited access or trouble with follow-up, I'm thinking of like the homeless shelter population. I can see a lot of benefit to this, but there's some things I'm concerned about still, that I have questions on. Because, it sounds like, oh, anyone can just call and ask for this, but you can't. You're not actually a medical service. Like, people could come to the clinic in Harlem, but if they wanted this to come to their home, they have to be working with a provider who's working with you, correct?
Yeah, I mean, so we would come to that based on insurance, obviously, right? If we're accepting their insurance, then they're obviously in network, and we would be able to come and see them. It would be our provider network, or it would be their providers if their providers are working with us. So, yes.
So just to break that down more, and I do want to talk about like what insurance in New York covers it and what the limitations of that are, because this has to be very expensive. But say I'm an Aetna and you're a provider in Aetna. I could make you my primary care and then you would come to me, or my doctor has to be connected to you. Like,
so I think
really break it down for people.
Yes, I think there's two things going on, right? If you're coming to the Harlem clinic, that's a medical clinic. And we take today, I think it's 11 different insurances, Medicare, Medicaid, and a whole bunch of the managed Medicare, Medicaid plans and some of the private plans. And so if we take your plan, we can provide care. And it's obviously our doctors, right? It is a medical practice in that location. If you're you're a clinic or a provider that's a customer of Medpod, right, and you own Medpod equipment, they could dispatch that equipment to your home, or they could use that equipment when you come physically into their location. And so you don't have to be part of the MediLink network. You could be part of your own network.
So there's 3 ways to get the service, and actually one of those ways it comes to you. The other ways you have to go somewhere.
No, I think in all cases it could come to you. If the provider, your provider, is working with Medpod, owns a Medpod piece of equipment like a mobile dock, they could dispatch it and it come to you. If they're interested in actually joining the MediLink WellCheck network, right, the one that's operating in Harlem on 45th Street, they could join our network. We're happy to have more doctors join us. We believe in local healthcare. And so, but there's also barriers, right? Many doctors say, well, I don't have time to do this. And so I'm not interested in joining any other networks, but they're welcome to join and actually come out and see you, and they would bill it through the normal channels.
And they bill, sorry, Kurt, I got
go ahead. We got you.
So the patient would be billed for the doctor's time and billed for the Medpod equipment, and what % of that then ends up being covered by insurance?
No, they wouldn't be privately billed. They would actually, it's covered under insurance, and it's 100% under insurance. Just as a little bit of a background, I mean, one, it's fully reimbursable, right, based on as long as you were in network with that insurance company. But further, as a global comment, or at least a national comment, it complies with what's called the parity laws. 2011, California was the first state to actually propose what became known as the parity laws. It was the Telehealth Advancement Act of 2011, ran into law January 1st, 2012. And that was the beginning, right, of you have to reimburse, the insurance companies were mandated to reimburse for care delivered virtually on par with a physical visit, but there are certain rules. It's not telemedicine. It's actually what we're calling telediagnostics or diagnostic telemedicine. And we built to that law. When we actually started building, it was well over a decade or even a decade and a half ago. We were very much conscious of being compliant with that law. That has been copycatted about 45 times, and so including in New York. So it's mandated that private insurance has to pay the doctor, right, for care on par with a physical visit. It's not that they're charging the patient. And then COVID came along, and then everyone started paying for it. In this scenario, it's still being paid for. Medpod is still being paid for. It's not classified as telemedicine. It's considered direct oversight, virtual direct oversight, and that's still mandated.
Good. So I'm thinking about something.
Jack.
Go ahead, Ed.
I want Jack to talk about Parker, Texas, and what we're doing there with the school system and how that situation developed and came about.
Yeah, there's an example. Ed's talking about the Parker County Hospital District, which is in West Texas, very rural area, where we're actually at this point up to about 70 locations, 70 schools that have Medpod in the schools, and the doctor back at the main hospital. It's actually one full-time doctor and 2 part-time nurse practitioners that provide care for all 70 communities. And it's not just for the students. It's actually they turned it in. For the entire community. So it's for the students, the teachers, the administrators, and all family members associated with the school. And so that created really an access point for the community. But for those kids that are in the school, instead of them actually leaving when they're not feeling well, they're seen really right on spot. Their parents or guardians brought right into the session, so they could actually watch what's happening with the provider, and then they could get their script if necessary. And they could deal with it without the cost, right? The direct cost of picking them up, taking them to the doctor, missing school, and so on and so forth. So it's become very effective. We have many programs around that, around the country of school-based healthcare. Again, not just for the students, but actually as a community center.
And quick question, Jack, because let's say most, insurances people have are in network or covered with a Medpod. But there are those who are not. So, for instance, me, U.S. Healthcare. What are we talking about?
So I don't have the list offhand. But again, I know the Harlem Clinic currently has 11. Now there's 4 or 5 additional ones that we're pending on. And then, of course, you always have certain ones that they say, well, we have enough coverage in the area, even though we disagree. So we are working with our local politicians to help deal with that.
Gotcha. And Dr. D, tell me, in the population that you service, do we see a lot of insurance coverage or no? Is it like
really mixed? As you know, insurance is based on employment, so which is a huge problem with our system. So there is in Harlem a large Medicaid, Medicare population, a lot of people who are on the marketplace or New York State of Health.
Yes.
Less private insurance. So that's why I was so concerned about coverage and the ways of coverage. I think the other thing I'm concerned about is the potential for over testing. Because, people used to say, oh, there's so many things that could potentially be wrong. Why don't I just get a full body scan? And the reason why you don't is because you're going to come up with a bunch of things that are slightly off that turn out to be nothing, but you go through a lot of testing to figure that out once you do the initial test. So I do worry about what is in place to prevent that when you say, oh, we're having the recordings of the heart stored now, and we're doing this further baselining. Like basic baselining is great, and it should be what primary care wellness appointments are. But then how do you make sure you're not over testing and going down paths that lead you to needless testing for minimal answers or no answers?
Yeah.
I think I'm a great example of that in myself, my own personal story, in that I've always believed in baselining, and we do this comprehensive initial baseline. In my case, I have indications that I should actually do a test that's an expensive test, quite frankly, called Cancer Check. And so, in that scenario, the reason why my care plan, right, based on the baseline creates a care plan. and then a course of action, right? And working with the patient almost in a concierge care approach with no additional cost, I should note. But in my scenario, because I am a brain tumor survivor, there was a concern, right, that I should actually go for further testing. And there's a concern in that particular case about 5 or 6% of the people that we touch that should actually do such a test. And so it is conscious, right, that you can't afford to have everybody going through every type of test. The ideal scenario, everyone does have a body scan. I would have been a perfect example. I would have thought they would have found my brain tumor, which was very large, right, years before. If I kept up, and I'm saying that very, very seriously, if I kept up with my brain scans, I was one of the few people that believed in body scanning. I actually did it in my 20s and 30s. I stopped because I was told exactly that. Well, you shouldn't be doing this. This is too much testing. And I ultimately missed it, and then actually had a front left lobe tumor that was the size of a baseball. And so, those type of things are scenarios that, again, the proper baselining, the proper type of programs, hopefully we wouldn't have that issue.
So I'm curious, Jack. So your brain tumor, did you have that before you developed MedPod, or did that spur you on to develop? I'm curious how that impacted your development of this business.
Yeah, no. So it was discovered for me, but in 2018, I was already well in the development of MedPod and other things, but it did actually push forward the whole baselining concept, right? So it really pushed it forward, saying, how do we catch these type of things? And again, I said it before, I was a fan of full body scan, and if you think it's important and you're willing to pay for it, no one's going to stop you. And so I was doing that in my 20s and my 30s, which was pretty early on, right, to do stuff like that. But again, it was the experience that I stopped because of the fact that people said, you're crazy. You shouldn't be doing this. You don't need to be doing this. You have no indication of it. And for me, it was missed. It was something that ultimately was a missed opportunity. Thank God I survived it. I have a titanium skull. I don't have the normal head, so to speak, but I survived and I'm good, right? So that's a good outcome. But yes, it definitely played a base on the baseline. It definitely played a role in it.
Gotcha. And Dr. D, I certainly hear what Jack is talking about, and I heard what you said in terms of the full body over testing, over scanning, whatnot. But I would say in Black and brown communities, unless I'm like bleeding out, we don't go to our health professionals. So could you concur on that?
Oh, yes, there's under testing, under care, absolutely, in Black and brown communities. I absolutely concur with that. I just, it's a cascading effect. Once you go down a certain road and a doctor finds something, many times they then look and look and look, and we don't want to put people in that position. At the same time, there is too much of a history of Black and brown communities not being listened to in the medical community. We see this all the time, particularly with women. It's why the Black maternal morbidity and mortality rates are so high, because they weren't listened to when they said something's wrong or something wasn't followed up on. So, there's both extremes playing.
Yes.
Well, let me share this.
Go ahead.
About 6 years ago, I was at the VA hospital, and they run the blood work, and they says that I had prostate cancer, and they were, they got that 12 needle approach, and I wasn't sure about that. So Jack and I had a conversation, and I shared with him. I said, Jack, some years ago, I had a detached retina when I was living in New York, and they did laser surgery. And he said, well, why don't you look into that and see whether we can find someone that may be able to help you with your prostate cancer. Well, I went to work, and it took a while. And I found the name of the doctor. His name was Dr. Danny Sperling. He's down in Palm Beach, Florida. And they said he was in either Yonkers or Mount Vernon. And then what happened was I checked, and then finally someone says he's no longer there. And I'm saying, well, why would he have moved? But what had happened was the rental space situation had occurred, and he stayed in Florida. But long story short, I did focal laser ablation and he has prostate cancer, right? So from that perspective, he built a machine. He says, Ed, it took me a long time to create and build the right MRI machine. He treated me, and for 5 years, I didn't have any issues. And then a slight opening came probably about 4 or 5 months ago, and then I was treated for that. So, and I'm good to go. So it all worked out, and that's why Jack and I, we and based on what Dr. Greene is saying, we've looked at all of these areas to make sure, and when we see those issues, we put a check mark by them and says, okay, we need to look at that more thoroughly, because if you look at what Jack has built here, and he hadn't even touched base with his relationship, with Henry Schein. So that I'll yield back to Jack.
Yeah, Jack, do tell us about that relationship with Henry Schein.
Yeah, I mean, they're Henry Schein being the largest ambulatory distributor, medical distributor in the world. They were actually one of the founding partners of Medpod. It was together in conversation myself and the chairman, Stanley Bergman, many years ago. It actually goes back to 2008. And so they became major supporters. We actually carried the name Henry Schein in the marketplace on top of the Medpod brand. And they brought some major companies in as well. So companies like Welch Allen, which is today Baxter Hillrom, companies like Midmark Corporation or direct investors sit on our board. Hariba Corporation, one of the big companies in laboratory. Obviously, there's others like Intel, Massimo, and so on. So they were very important, right, in actually helping bring some of the best in healthcare to the table, and actually enabling us to build this platform. And it wasn't easy. There was a lot of actually opposition. I remember the original conversation where Stanley says, go to the big telemedicine companies. And if you go back into 2008, 2009, it was Polycom, Cisco, and LifeSize. And they all actually said, no, we're not willing to help you. But Cisco went one step further. We said, not only are they not willing to help, we actually hope you fail. And I said, well, if you're willing to say that, why? And they said, if you're actually successful, you would disrupt our business model for healthcare. And so we walked out of that meeting saying, okay, we need to build this. Because if a company like Cisco is hoping that we fail, we're onto something.
Okay. No, I hear that. Bob, what you got?
Oh, just listening. I mean, I'm very pleased to hear the progress you've made. Jack, also tell me a little bit about this. I was kind of just peeking at your bio there and saw that you got an award from the Pontifical. What?
That's the Vatican. Yes, I won the 2024 Medal of Honor from the Vatican for the work that Medpod is doing.
Okay.
Did you meet the Pope?
I didn't meet the Pope. Actually, one of our doctors is the doctor for the Pope, and I was with him in Rome, and he said, "Come, I want to take you and your son to this phenomenal coffee shop." And he left us right on the side of Vatican City. And I'll be right back. And then he came back about an hour later. I said, "Where'd you go?" He said, "Did you enjoy the coffee?" I said, "It was phenomenal." But where'd you go? He said, "Well, I couldn't take you in to see the Pope. He wasn't feeling so well."
Got you. I was good. So, and of course, Dr. D, tell me this. So one of the things that had come into the community, I think some years back, I would say before, of course, lockdown and COVID and whatnot, was, of course, City MD that I started to notice them. Do you see a parallel here? Tell me. What do you think? In terms of the walk-in aspect.
Sure. I mean, I think that the idea of like a City MD or the Medwell Harlem Clinic is the idea that you can get access to healthcare when you need it, in your community. So, I think, and they have all the equipment of a normal doctor's office. I used them myself once to determine whether or not I had the flu when I was at work and feeling horrible. And it was easy, right? You have
Yes.
to make an appointment with your doctor. They can get you in right away. They have doctors, they have nurse practitioners. They can send out labs. So it's similar. I think it's just, one's more person-based, one's more technology-based.
Right.
The idea is any access that anything that increases access to care to community is good, but I also believe that we want a continuum of care. This is why we don't want people constantly going to the emergency room.
Right.
Or constantly going to urgent care. You want people to have a place they can go to for consistent care. It's, why baselines are so important, because you have someone who knows how you're changing because they know how you were the last time they saw you. We would love for people to have healthcare homes. This seems like a way of digitizing that, right? So that information's captured and there no matter where you go. I think, we'll see as it grows how much of that for a community like Harlem, that information really is there for people every time they go seek health care as they bounce back and forth, as we know they will, between the Medwell Clinic and Harlem Hospital.
Oh, wow. Yes.
And their specialty care, is everyone going to be able to access that great comprehensive baseline? And will it help determine people's care? I think that's what the dream would be, right?
And Jack, comments?
No, I agree. I mean, this is at least on the MediLink Medpod, the clinic. It is using technology to bridge the gap. But we also very much believe in the continuum of care and in patient-centric healthcare. And I was a leader in a lot of those movements, right? In going back 10, 15, 20 years. And so we're really trying to bring that all together. One of our doctors makes a comment that he was pretty strong on. The primary care doctor has to be in person, and he has to have that relationship with the patient, and it's all about that long-term relationship. And about a year ago, he finally conceded and said, "That's dead." He was like, "I wish it was like that, but the reality is that with the advent of urgent care, which is good and it's convenient, but it does break that continuity to a certain degree, and patients are accessing care in multiple different places, and we don't truly have the data together, right? I mean, we would like to. In an ideal scenario, all of your data is traveling with you, but the reality is that it doesn't do that effectively yet. And so we do believe that ultimately that file and that baseline is going to become very important to inform the doctor that's treating you of your current situation, and then look at deviation from the norm.
Gotcha. Night Watchman, you didn't realize and whatnot. We're already in the lightning round.
Yeah, that's right. That's right. So each one of you has a chance to give us some final wise words.
Okay. Who you want to start with, Night Watchman?
Let's start with Ed.
Ed, yes.
Well, my final words are healthcare is essential. I'm one of the original founders of Harlem Churches for Community Improvements in Harlem.
HCCI.
HCCI, and one of the primary goals, working with Y.T. Walker, Preston Washington, Bishop Norman Quigg, and others, was housing and healthcare. And when I met Jack, I said, Jack, we have housing to a degree. We still need more housing, naturally, affordable housing. I said, but we need good medical health care for our community. And Jack has stepped up to the plate. Now, and trust me, I'm a former captain, United States Air Force. I used to work for 3-star general, so I'm going to check you out now. And I checked him out at every point. I haven't gotten that X yet, so either he's just that good or I'm just that bad. But I believe, when you find, and like I said, I'm no stranger to New York. I was a design engineer for Conrail, and been in Harlem, East and West, and see the need for good community health care. And Jack brings that to the table for us as a community.
Gotcha. Thank you. Jack, what you got for us?
I think very, very simply, I'm going to say, in order for this to work properly, people have to come in, right? They actually have to experience it. So nothing more important than actually coming in, feeling and experiencing the clinic at 145th Street and Malcolm X Boulevard. And then if you need us to physically come out to you, again, in the scenario where there's sick and shut in, or there's, they're in, skilled nursing facilities or long-term care or whatever it may be, we're happy to come out and actually provide care in the community directly. And so, we started in Harlem. Ed said if you could actually make it start in Harlem and make it successful there, it could literally work anywhere. So while we already have 500 or so out in the world, this is actually our first direct clinic that we built as Medpod.
Beautiful, beautiful. Dr. Danielle Greene.
Bringing it home.
Yeah, bringing it home.
I think it's an amazing opportunity. I look forward to seeing how it plays out in the clinic. And I think that there's public health applications that can be explored, like we talked about, like when people are congregating in emergency shelter, bringing it in to homeless shelters and other congregate settings, partnering with home visiting programs and home health programs. I think there could be a real benefit in those areas.
Beautiful.
I think, technology is great. We just also have to be careful how we use it.
Indeed, indeed. So, Night Watchman, are you prepared to take us home?
I am prepared to take us home. All right. So you're listening to Soul Lounge Prime Time on WHCR 90.3 FM, the voice of Harlem. Also live streaming on Facebook and YouTube. You can find us on Monday nights, 7 p.m. on the radio, 90.3 FM, and 8 o'clock live on YouTube and Facebook. Thanks for our guests for not only informing us of what they're doing, but just for their work in terms of making healthcare more accessible to all.
Indeed, indeed. And Night Watchman, are they all coming back to the cookout?
Absolutely.